Good morning, students. Let us start our lecture. You see, the theme is anti-diabetic agents. Anti-diabetic agents means the drugs to treat diabetes mellitus. Diabetes mellitus. The term diabetes in Greek means increased urine output or polyuria. Polyuria. We distinguish diabetes mellitus, diabetes insipidus, but today we will discuss diabetes mellitus. So diabetes mellitus is defined as an elevated blood glucose associated with absent or inadequate pancreatic insulin secretion, with or without concurrent impairment of insulin action. Nowadays, we distinguish four main types of diabetes mellitus. Type 1 is characterized by severe or absolute insulin deficiency due to the destruction of beta cells of the islets of the pancreas. Type 1 diabetes is further subdivided into immune-mediated, type 1A, and idiopathic causes, type 1B. The immune form is the most common form of type 1 diabetes. Although most patients are younger than 30 years of age at the time of diagnosis, the onset can occur at any age. All patients with type 1 of diabetes mellitus need insulin therapy. Type 2 diabetes mellitus is a group of conditions characterized by tissue resistance to the action of insulin combined with a relative deficiency in insulin secretion. Although the circulating endogenous insulin is sufficient to prevent ketoacidosis, it is inadequate to prevent hyperglycemia. Patients can initially be controlled with diet, exercises, and oral glucose-lowering agents or non-insulin injectables. Some patients have progressive beta cell failure and eventually may also need insulin therapy. Short name of type 1 is insulin dependent, of type 2 non-insulin dependent. But pay attention, non-insulin dependent type 2, some patients also need insulin therapy. Type 3 diabetes mellitus includes other specific causes of an elevated blood glucose. For example, pancreatictomy, pancreatitis, non-pancreatic diseases, drug therapy, etc. And type 4, or gestational diabetes mellitus, is defined as any abnormality in glucose level noted for the first time during pregnancy. Gestational diabetes is diagnosed in approximately 5 to 10% of all pregnancies in different countries. More often, we meet patients with type 1 insulin dependent and type 2 non-insulin dependent. What is insulin? Insulin is a hormone of protein chemical structure which is produced by beta cells of pancreatic islets. So hormone, protein hormone produced by pancreatic beta cells. The role, basic role of insulin, this is activation of transport of glucose through cell membrane and activation metabolism of glucose within the cell. So insulin binds to insulin receptor. Insulin receptors localized in cell membranes of different tissues. So molecule of insulin binds to alpha subunit that causes transformation of structure of beta subunit that activates protein kinase, tyrosine kinase. That leads to first activation of glucose transporter. This is transport system localized in cell membrane. It's first activation of transporter and promotion of transport of glucose. And second, activation of metabolic reactions happened to glucose molecules. First of all, this is formation of glucose 6-phosphate, and synthesis from glucose 6-phosphate of glycogen, its first part, and second part, glycolysis with synthesis of ATP, essential for all biochemical, biophysical processes in every cells. Nowadays, we distinguish several types, as you see, of glucose transporter. 1, 2, 3, 4, 5, localized in different tissues. GLUT1 in all tissues, GLUT2 pancreatic beta cells, GLUT3 brain, kidney, placenta, and so on. Subtypes of glucose transporter localized in different cells. And function is activation of uptake of glucose from outside to inside of the cell. In pancreatic beta cells, this is regulation of insulin also and other aspects of insulin metabolism. So it's first part of mechanism, activation of glucose transporter that promotes transport of glucose from outside to inside and elimination of increased level of glucose. What are the metabolic effects of insulin? Because second part of mechanism, this is activation of metabolic processes inside the cells happening to glucose. So action of insulin. It decreases glucose level in blood. It's first of all increasing uptake by the cells of glucose and other substances, and activation of key enzymes of glycolysis. Insulin possesses anabolic action in the cells. It increases intensity of glycogen synthesis, activates uptake by the cells of amino acids, especially leucine and valine, activates transport of potassium, magnesium, and phosphates into the cells, activates DNA replication and biosynthesis of proteins, activates synthesis of fatty acids and triglycerides. Anticatabolic effects of insulin, inhibits intensity of glyconeogenesis, saving amino acids, decreases degradation of proteins, and inhibits lipolysis. So, in insufficiency of insulin, hyperglycemia is developed. At the same time, insufficiency of glucose inside the cell and change of all types of metabolism to facilitate synthesis of ATP. Increase of glucose level in blood causes increase of filtration of glucose in kidneys and high level in urine, which is not completely reabsorbed in glomeruli. That is why in final urine there is certain level of glucose urea. Glucose urea causes increase of osmotic pressure and binding of water. That is why volume of urine is increased. That is why a patient suffers from polyuria. This is first symptom of diabetes mellitus. But polyuria provokes thirst. This is second sign. And after all the rest. How is insulin secreted by beta cells? All time or not all time? First of all, beta cells of pancreas secrete insulin really all time, but not high level, low level. And we call this basal insulin secretion. But because of increase of glucose level in blood, secretion of insulin every time is increased. Increase of glucose level takes place after every meal. That is why basal secretion of insulin after meal is increased, secretion is increased, and we see the peak. And this high secretion of insulin lasts for 3 to 4 hours. And we call it prandial or postprandial. It means after meals. Postprandial hyperinsulinemia. After decrease to basal level and next taking of food, again increase of insulin, postprandial, again basal secretion, next taking of food, increase of insulin, and all time. We should understand this scheme of secretion of insulin because we should model this situation in patients with type 1 diabetes mellitus. We should model exactly this physiologic regimen. Basal secretion, but after meal to utilize glucose, more secretion. Basal secretion, after meal, more secretion. And we should introduce insulin to the patients by this regimen. So now we understand that type 1 diabetes mellitus requires insulin preparations. Insulin preparations. We started to use insulin preparations from 30s years of last century. First of all, we obtained insulin from animals, and we used animal insulin. For example, porcine from pigs, cattle, or bull, whale. Nowadays, we are able to produce human insulin by the methods of genetic engineering. Of course, we should understand that it's much better to use human insulin. Among animal insulins, the best is porcine, because it differs from human by only 1 amino acid. Cattle differs by 3 amino acids, and whale insulin more than 3 amino acids. More. Nowadays, more often we use human insulin, sometimes, very rarely, porcine insulin. By the level of purification, preparations of insulin are divided by 3 groups: traditional, monopeak, and a monocomponent. Traditional, this is old insulin, not sufficiently purified from impurities of other pancreatic hormones. Monopeak, content of impurities not more than 1 times 10 power minus 3. And the best is monocomponent MC, content of impurities not more than 1 times 10 power minus 6. This is the mostly purified preparation of insulin. Animal insulin or human insulin itself is called regular insulin. Regular insulin acts, we should take into account half-life period. So it acts approximately 5 to 6, maybe a little more hours, regular. But nowadays we have preparations of insulin with longer action duration. How? Regular insulin we call short-acting insulin, and with prolonged action. How can we prolong? By adding to insulin of specific supplements. Zinc, for example, protein, and these supplements make preparation of insulin suspensions, and suspensions are absorbed slowly. And depending on supplements, preparations of insulin divided by intermediate action duration is longer than short-acting, long-acting, ultra-long-acting. And nowadays, we have analogs of human insulin, preparations of human insulin with ultra-short action, or very long action but peak less. Ultra short or very long. Look, if this is regular, and this is example of prolonged NPH neutral protophane hagedorn with supplement of protophane acting longer. But this one acts shorter than regular. Short acting and fast acting insulins. And there are peakless insulins acting long. How? And we see the names: insulin lispro, aspart, glulizine, insulin detemir, insulin degludec, insulin glargine. These are preparations of insulin in which certain amino acids are changed. And this change of amino acid causes change of pharmacokinetic properties. Insulin lispro, lysine and proline are changed, for example. And we see that action duration not 2, 5, 6 hours, but 3 to 4 hours, and beginning of effect is faster. Regular insulin, if we introduce, we understand that protein preparations are introduced by injections, so it starts to act in 30 minutes like this. But short acting is fast acting. The onset is in 15 minutes. Fast onset and fast end of effect. We understand that this kind of preparation we can use for modeling of postprandial glycemia. It's first. And second, we can use fast-acting insulins for the most severe complication of diabetes mellitus, which is hyperglycemic coma. In comatose state, we should help to the patient very fast. That is why it's better to use the fast-acting preparations. It's first. For what do we need long-acting, peak-less insulins? Detemir, degludec, glargine. For modeling of basal secretion. And one of regimen of introduction, we can introduce one of these peakless insulins, and before meals we can inject fast and short acting insulin 1, 2, 3. So there are insulin preparations and analogs of insulin in which certain amino acids are changed. Ultra short acting and peakless long acting. Once again, this is example. Introduction of insulin glargine, and this is continuation, which lasts over 24 hours. This is modeling of basal secretion. And all time before meal, we introduce analog, fast-acting analog, for example, insulin lispro. And we have basal secretion and postprandial increase of level of insulin. Basal, postprandial. Basal, postprandial. Postprandial is essential for utilization of glucose. And now some preparations of insulin. Fast-acting insulin or analogs. We have discussed. These are analogs. The effect begins in 5 to 15 minutes after injection. Maximal effect after 1 hour. Total duration 3 to 4 hours. 3 to 4 hours. Insulinless Pro, trade name Humalog, for example, can be different names. Aspart or Nova Rapid. Glulizine, Epidra, for example. Short-acting insulin. This is regular insulin. Once again, more often we use human, very rarely porcine. Effect begins in 30 minutes. Maximal effect 1 to 2 hours and duration 5 maybe to 8 hours. Examples: Actrapid, regular Humulin, Humodar P porcine, Pharmasolin H human. Intermediate acting insulin. These are suspensions of regular insulin. The effect begins after 1 to 1.5 hours. Maximal effect after 4 to 12 hours in different preparations. And duration of effect in different preparation 12 to 20 hours. Examples: Protafan, Monotard, Humulin NPH, Humodar B, Pharmasolin H and P. Human neutral protophane, neutral protophane human, Hagedorn, Hagedorn. Next subgroup, long-acting insulin, long-acting. These are analogs. Begin working within 1 to 2 hours and continue to be active without major peaks for about 24 hours. Insulin Glargine, trade name Lantus. Insulin Asparagine, Novamix Flex Pen, White Pen. We introduce insulin by injections, and we introduce insulin several times every day, the whole life. This is very serious problem. Injections. That is why we use special devices. First of all, special syringes and special needles, very, very thin needles. It's first. Second, like pen devices. An injection with these devices not painful. Nowadays, we also use special pumps for constant introduction subcutaneously. And the last, nowadays we already have preparations for inhalation. Tiny particles of insulin, molecules of insulin are inhaled. But this is the latest form, and maybe in several years we will use in the whole world. Of course, if we will use in inhalations, it's very good because no need to inject. Because long usage in injections causes development of lipodystrophies. It's first of all specific changes in subcutaneous fat. Sometimes allergic reactions, and so on. Let's continue preparations of insulin. Next group, ultra-long acting insulins. Ultra-long. Begin working within 30 to 90 minutes and act more than 24 hours. Ultra-long Detemir, trade name Levemir, insulin degludec or Tricybe, and the last, combinations, combinations more often of short-acting and long-acting. We economize one injection. This combination start to act fast, and this is modeling of first taking of food, but long-acting pickless model basal secretion of insulin. Examples: Actrafan, Mixtard, Humodar, Novolog, and so on, and so on. These are preparations of insulin. How do we dose insulin preparations? One of methods of dosing is every 4 to 5 grams of glucose excreted from the organism for 24 hours require 1 unit of insulin. For calculation, we should first gather the urine for 24 hours. After, we measure volume and concentration of glucose and calculate how much glucose is excreted, is in urine, or is excreted. For example, 100 gram glucose is excreted from the organism for 24 hours. If 100, I told you 4 to 5 gram needs 1 unit. So if 100 gram per 24 hours, it means daily dose of insulin is 20 to 25 units. Approximately 20 to 25 units. I told you that insulin is used the whole life. That is why it's necessary to take into account interaction with other drugs. Because some drugs increase activity of insulin, some drugs decrease activity of insulin. What does it mean, activity? Transportation of glucose to the cells, elimination of hyperglycemia. This is activity of insulin. So, following drugs enhance the hypoglycemic effect of insulin. Beta blockers, beta adrenergic blockers, sulfonamides, anabolic steroids, inhibitors of monoamino oxidase. These are examples. And some groups weakening hypoglycemic effect of insulin. Thiazide diuretics, glucocorticoids, thyroid hormones, heparin. These are examples of drugs changing hypoglycemic effect of insulin. The most severe complication of treatment by insulin is hypoglycemia. We use insulin in hyperglycemia or diabetes mellitus. But if we use more dose and cause hypoglycemia. Hyperglycemia can cause comatose condition, and hypoglycemia can cause comatose condition. And comatose condition require immediate help. Hyperglycemic coma, we introduce insulin it's better to use fast-acting or analogs of insulin intravenously. If this is hypoglycemia, what should we do? First of all, it depends on what preparation of insulin was used. If it was a regular insulin or ultra short acting or short acting regular, we can use only glucose. And a patient feels specific manifestations of hypoglycemia. And in these manifestations, a patient takes something sweet, or sweet tea, for example, or sweet any. If a patient is unconscious, we can introduce glucose or dextrose intravenously. But if we have used preparations of insulin with prolonged effect, in hypoglycemia, usage of glucose is unhelpful. Because we introduce glucose, but insulin promotes transportation of this glucose to the cells. That is why we should use biochemical antagonists of insulin. Biochemical antagonists of insulin are, first of all, hormone, also protein hormone of alpha cells of pancreas, glucagon, and second, epinephrine preparations of adrenaline. They both are biochemical antagonists and eliminate acute hypoglycemia. Break. Let us continue our lecture, students. We have discussed about preparations of insulin, and now non-insulin antidiabetics, synthetic drugs, which are used mostly for treatment of second type of diabetes mellitus, non-insulin dependent diabetes mellitus. Principally, we distinguish 6 groups. First group, drugs stimulating endogenous insulin secretion, or insulin secretagogues. Insulin secretagogues. Second group, drugs promoting glucose transport to cells and inhibiting glyconeogenesis, or acting like insulin. Third group, drugs that decrease insulin resistance of the cells. Fourth group, drugs inhibiting glucose absorption in intestine. Fifth group, drugs increasing glucose excretion with urine. And sixth group, different miscellaneous anti-diabetic agents. First group, drugs stimulating endogenous insulin secretion. This group includes 3 subgroups. First of all, blockers of ATP-sensitive potassium channels of pancreatic beta cells, incretin mimetics, and third one, amylin analogs. Let us discuss a little about every group. So, blockers of ATP-sensitive potassium channels of pancreatic beta cells include sulfonylureas and meglitinides. Sulfonylureas means chemical structure, derivatives of sulfonylurea. Nowadays, we distinguish preparations of the first generation, which are old, and later preparations, second, third generation. First generation includes chlorpropamide, carbutamide, tolazamide, tolbutamide. Nowadays, they are used very rarely. And second, third generation include glibenclamide, glyclazide, glyquidone, glipizide, glyburide, glimidine, and glimepiride. Glimepiride belongs to third generation. Mechanism of action of all of these drugs is stimulation of so-called SUR1 receptor, sulfonylurea receptor, of ATP-sensitive potassium channels in pancreatic beta cells. Stimulation of these receptors causes blockade of these channels, resulting in depolarization of the cell membrane, activation of calcium influx that stimulates insulin exocytosis from pancreatic beta cells. Sulfonylurea derivatives can reduce hepatic glucose production and increase peripheral insulin sensitivity. Preparation of first generation cause long-lasting insulinemia. That is why nowadays we don't use them. Third and third generation cause shorter insulinemia. That is why usage of these drugs less cause different side effects associated with hyperinsulinemia, long-term hyperinsulinemia. Possible adverse effects: weight gain, I told hyperinsulinemia, and hypoglycemia. One of the most popular nowadays is glimepiride. Glimepiride is approved for once daily use as monotherapy or in combination with insulin. It achieves blood glucose lowering with the lowest dosage of any sulfonylurea compound. A single dose of this drug is 1 milligram. Maximal single dose is 8 milligram. Glimepiride's half-life under multi-dose conditions is 5 to 9 hours. It is completely metabolized by the liver to metabolites with weak or no activity. So we use the drug once daily, and the drug causes a like postprandial insulinemia, short-lasting insulinemia, lasting for 3 to 4 hours. Meglitinides or glinides sometimes are called regulators of postprandial glycemia. Classical drug is repaglinide. Repaglinide has meglitinide structure, and second representative has another structure but same mechanism of action and effects. D-phenylalanine derivative, nataglinide, repaglinide and nataglinide. Mechanism of action is associated with blockade of ATP-sensitive potassium channels, resulting in depolarization of cell membrane, activation of calcium influx that stimulates insulin exocytosis from pancreatic beta cells. So mechanism is very close to mechanism of action of sulfonylurea. But these agents have two binding sites. First site is in common with the sulfonylureas, but the second site is unique binding site. Unique binding site. Glinides have rapid onset and short action duration. Therefore, apply 15 minutes before each meal. A patient takes the drug 15 minutes before meal, and this causes insulinemia for 3 to 4 hours, essential for utilization of postprandial hyperglycemia. Adverse effects: weight gain, hypoglycemia. Both these drugs are approved as monotherapy or in combination with biguanides. For example, metformin. Second subgroup of stimulants of insulin secretion. Second subgroups. Look. Incretin mimetics. They include GLP analogs and DPP-4 inhibitors. First, analogs of GLP-1 and GIP. GLP-1, this is glucagon-like polypeptide. GIP, this is glucose-dependent insulinotropic peptide. Both these peptides are incretin hormones or incretins. These hormones produced by the gut, specific cells of the gut. They potentiate glucose-mediated insulin secretion, decrease postprandial glucagon secretion, but glucagon is contra-insulinic factor, and promote beta cell proliferation. Besides this, they slow gastric emptying time and reduce appetite. This is physiologic function of incretins, GLP-1 and G. Nowadays, we use analogs of GLP-1, liraglutide, semaglutide, dulaglutide, exenatide, lixisenatide, and the latest preparation, tirzepatide, is double agonist of GLP-1 and GIP receptors. This is the newest preparation. These preparations are effective but introduced in the form of subcutaneous injection. So the principle of their action is stimulation of insulin release and inhibition of glucagon release. But these agents can cause side effects: nausea, vomiting, diarrhea, constipation, and pancreatitis. So these are incretin mimetics. In our organism, incretins, GIP and GLP, are cleft by specific enzyme, dipeptidyl peptidase 4, DPP4. There is the group inhibitors of this enzyme, DPP4 inhibitors, which are introduced orally, not by injections. But inhibiting this enzyme, the drugs promote prolongation of action of natural incretins. Sitagliptin, vildagliptin, saxagliptin, allogliptin, linagliptin, gemigliptin, evogliptin. Possible preparations used in different countries of the world. So, mechanism of action, once again, inhibition of DPP4, which is enzyme cleaving GLP-1 and GIP, increases activity of natural incretins and causes increase of insulin release in response to meals and reduces secretion of glucagon. Unlike incretin mimetics, these drugs don't cause satiety and are weight neutral. DPP4 inhibitors may be used as monotherapy or in combination with sulfonylureas, biguanides, thiazolidinediones, or insulin. These agents, DPP4 inhibitors, are well tolerated, so side effects are developed rarely. And the third subgroup, promoting stimulation of insulin release. Amylin analogs, islet amyloid polypeptide, IAPP, islet amyloid polypeptide, short name amylin. This polypeptide is released also from pancreatic beta cells, like insulin, and reduces appetite, delays gastric emptying, decreases glucagon, and increases insulin secretion, inhibiting absorption of glucose in gut. Nowadays, only one drug is available, pramlintide, which is used by subcutaneous injection. So we have discussed about agents stimulating secretion of insulin. Second principle, the drugs acting like insulin, inhibiting glyconeogenesis and promoting glucose transport to cells. Chemical name of this group is biguanides. Two drugs are available, buformin and metformin, but more often nowadays metformin exactly is used. Mechanism of action is not clear enough. Basic effects are reduction of hepatic glyconeogenesis and intestinal absorption of sugars, improvement of peripheral glucose uptake and utilization. Weight loss may occur because of loss of appetite. Metformin can be used or alone or in combination with other oral agents or insulin. Side effects: the drug can cause gastrointestinal disorders. It's necessary to say that exactly metformin is the most the used more often drug, the most popular for synthetic anti-diabetics. Third group, the drugs that decrease insulin resistance of cells. This group include thiazolidinediones or glitazones, and second one, agents decreasing insulin resistance of cells due to improvement of dopaminergic control of the circadian rhythm of hormone release. First, thiazolidinediones. They include pioglitazone, rosiglitazone, troglitazone. More often, pioglitazone and rosiglitazone are used. Mechanism of action of thiazolidinediones associated with stimulation of gamma PPAR receptors, gamma peroxisome proliferator activated receptors. These receptors modulate transcription of genes sensitive to insulin and participate in regulation of glucose level and lipids metabolism. Thiazolidinediones can be used as monotherapy or in combination with other glucose-lowering agents or insulin. But its dose should be decreased. Adverse effects. Very serious adverse effects. Liver toxicity, cardiac toxicity, especially for rosiglitazone, bladder cancer, weight gain, osteopenia, bone fractures. That is why these drugs are used relatively rare. But there is this mechanism, stimulation of gamma peroxisome proliferator activated receptors in cell membranes of different cells. So, bromocriptine is dopamine mimetic stimulant of dopamine receptors in CNS. In CNS. This drug, after one taken early in the morning, 1 time per day early in the morning. So, and this taken improves the control of the circadian rhythm of hormone release. Growth hormone, ACTH, prolactin, and so on. And so on. And the usage of this drug causes decrease of glycated hemoglobin. What is glycated hemoglobin? We should investigate level of glucose in blood, first of all, level of glucose in urine. Of course, first of all, we investigate glucose level before meal, and glucose level after load by special dose of glucose. But when we investigate glucose level, we know the level exactly this minute. But what level was 1 hour ago, 10 hours ago, or what level will be in 2 hours, we don't know. Because we investigate only this portion of blood. But level of glucose all time is different. Increased, decreased, increased, decreased. Glycated hemoglobin shows us long-term hyperglycemia. In normal situation, level of glycated hemoglobin is approximately 5 to 6, maybe up to 7%. But increase of this level shows long-term hyperglycemia. Long-term hyperglycemia, this is because of real suffering of diabetes mellitus. So, if we treat the patient, and if we investigate decrease of level of glycated hemoglobin, we understand that treatment is correct. So, one introduction of bromocriptine causes decrease of level of glycated hemoglobin in patients. Fourth principle and fourth group. Drugs inhibiting glucose absorption in intestine, or alpha-glucosidase inhibitors. Inhibitors of enzymes cleaving polysaccharides to monosaccharides. The names of drugs: acarbose, miglitol, voglibose. Besides these drugs, available is guar-gum. Guar-gum is cellulose obtained from seeds of Indian plant guar. Guar, or Latin name Ceamopsis tetragonolobus. This cellulose forms viscous gel in GIT. That's why delays emptying of stomach and absorption of carbohydrates in intestine. Decreases appetite. These drugs help sometimes to eat something sweet to the patient. Because we understand that treatment of diabetes mellitus is associated with very strict diet. Next group. Drugs increasing glucose excretion with urine. By the mechanism of action, they are CGLT2 inhibitors or inhibitors of sodium glucose cotransporter 2. Sodium glucose cotransporter. This cotransporter promotes absorption of glucose in glomeruli. That is why inhibition of this transport system causes excretion of glucose with urine from the organism. Nowadays, we have several preparations: canagliflozin, dapagliflozin, empagliflozin, ertugliflozin, ipragliflozin. All of them are used in different countries and principally are popular because they promote decreased glucose level in blood. So, mechanism of action we have discussed: inhibition of CGLT2 that leads to decrease of glucose reabsorption, increased urinary glucose excretion, and lower blood glucose. And the last, miscellaneous anti-diabetic agents. Epalrestat, tolrestat. Aldose reductase inhibitors. Inhibitors of enzyme aldose reductase. Inhibition of this enzyme decreases accumulation in tissues of sorbitol. Hyperglycemia, increased level of glucose, promotes increase of level of sorbitol, but sorbitol itself provokes neuropathies and angiopathies, the most serious complications of diabetes mellitus. So, usage of aldose reductase inhibitors decrease level of sorbitol and prevent development of neuropathies and angiopathies. And cholesevelam, bile acid sequestrant. By the mechanism of action, it is an antagonist of the FX or farnesoid X receptors. Farnesoid X receptors of the cell nuclei related to metabolism of cholesterol, fatty acids, and glucose. Usage of cholesevelam causes decrease of blood sugar level and glycated hemoglobin level. Abbreviation of glycated hemoglobin, hemoglobin A1C, HbA1c. HbA1c. And let us discuss about principle of usage of these drugs. Schematic diagram of diabetes mellitus treatment. So, new patient of diabetes. They are divided by type 1 patients and type 2 patients. In type 1, we use diet plus insulin. Situation is controlled. Incorrect choice of insulin and insulin therapy. Type 2. First of all, a patient should follow diet. Exercise, it's very, very important for type 2. And we use metformin, biguanide derivative. metformin. Situation is controlled. If uncontrolled, can be uncomplicated, well-nourished situation, and we use metformin plus one of drugs, sulfonylurea or meglitidenide or pioglitazone or DPP-4 inhibitor or alpha-glucosidase inhibitor. Situation after this treatment can be controlled or uncontrolled. If uncontrolled, we use metformin plus two drugs. One of them sulfonylurea, meglitidenide or DPP-4 inhibitor. Metformin first, this one is second, and third one pioglitazone or alpha-glucosidase inhibitor. Three drugs. Situation can be controlled or uncontrolled. After first usage of metformin, situation can be uncontrolled, uncomplicated, but severe, with underweight, complications present, pregnancy, if pregnancy, infections, surgery, we start to use insulin with metformin. If here situation is uncontrolled, we use insulin plus metformin and sometimes plus sulfonylurea or DPP-4 inhibitor or alpha-glucosidase inhibitor. For today, the lecture is over. Goodbye.